In this film, the application of a Vola forearm splint will be demonstrated. In this case, the patient is presenting with a distal radius fracture. In case the fracture is displaced, reduction may be required. This is, however, not demonstrated in this film. One of the other indications for a Vola splint is carpal tunnel syndrome. Splinting may be used as its first treatment option where the wrist joint should be splinted in a slightly extended position. A Vola splint can also be used to immobilize a fractured lunate bone. The advantage of a Vola splint over a dorsal splint is that a Vola splint causes less compression of the lunate bone, causing less pain complaints. Before starting the application, the arm is examined. Injuries to the wrist may be accompanied by elbow injuries. The elbow is examined for mobility and the head of the radius and the ulna are palpated to test for tenderness. The sensation in the thumb and other digits is examined, as is the capillary refill. All these examinations are used to detect abnormalities so they can be acted on if necessary. Also, the results can be compared to the physical examination after the splint has been applied. The following materials are required to apply a Vola forearm splint. One small stockinette with a width of 2.5 cm, a stockinette with a width of 5 cm, padding with a width of 7.5 cm, plaster, for an average size adult 8 to 10 layers should be sufficient, an elastic wrap with a width of 7.5 cm, medical tape, and bandage scissors. Do note that the size of the materials used depends on the size of the patient. The small stockinette is placed over the thumb. The length of the stockinette to be applied over the forearm is now measured. The stockinette should be long enough to cover the entire forearm and include the hand. A hole should be created through which the thumb is placed. The location is decided using the patient's base of the thumb as a landmark, and a small hole is cut. The stockinette is then rolled up and gently passed over the entire hand and entire forearm of the patient. Note that the stockinette is wrinkle-free, as wrinkling may cause irritation of the skin. Next, the padding needs to be applied. Care should be taken to apply extra padding over the ulnar prominence to avoid pressure complications. Too much padding should be avoided, as this may cause the splint to be too loose and be able to move over the arm, which may lead to scratches or blisters. The flat part of the roll should be applied onto the limb, allowing for easy unrolling. The application is started by encircling the wrist joint twice, making sure to include the ulnar prominence. It is then placed through the first web space, over the wrist joint, and again through the first web space. The padding is unrolled further proximally until the entire forearm is covered. Note that each turn of padding overlaps the preceding one by 50%. Note that the stockinette is left longer than the padding distally and proximally. Care should be taken not to immobilize the metacarpophalangeal joints. Therefore, the folded edge of the stockinette should be located proximal to these joints, as shown here. It is advised to check if there are no uncovered areas left. This should be avoided to limit the risk of thermal injury of the skin. How the plaster will be applied while dry is demonstrated. Note that the plaster is adjusted so that it fits in the palm of the hand. The plaster should be applied 2 finger breadths from the elbow crease along the volar side of the forearm and wrist joint. Water at room temperature is used, as too hot water causes the plaster to harden too quickly. The plaster is folded in a corrugated fashion, as now shown, and then dipped in the water for a few seconds. Excess water is now squeezed from the plaster, and it is then applied over the volar side of the forearm. It is shaped in a curved fashion so it fits well around the forearm. Note that the plaster is too long proximally. Therefore, the plaster is trimmed. Thereafter, the plaster is smoothened over the forearm to remove any wrinkles, with care taken to ensure no skin comes in contact with the plaster. The longer stockinette and padding are now folded over the plaster, creating smooth edges. Take note how this is done distally, leaving the palmar crease exposed. Also note how the stockinette is folded back over the thumb. Thereafter, the elastic wrap is applied to the limb in the same manner as the padding, with the flat part against the surface of the plaster and rolled in the same manner as the padding was previously. After the wrist joint is encircled twice, the wrap is cut and placed in the first web space. Although application of the elastic wrap is done under tension, care is taken not to put too much tension on it, as this may compromise blood flow in the digits. The elastic wrap is applied to the entire length of the forearm, as shown. In this film, plaster molding is demonstrated as would be for correcting a distal radius fracture with volar angulation of the distal fragment. The orthopedic cast technician places one hand on the dorsal side with the palm of the hand on the fracture, placing pressure on it in a volar direction. The other hand is placed on the volar side with the thumb distal to the fracture. The thumb places pressure in a dorsal direction while the wrist is slightly extended simultaneously. The other digits are placed proximal to the fracture. Altogether, both hands provide a 1, 2, 3-point fixation of the fracture, which is required to adequately support it. A combination of 3-point fixation and extension of the wrist joint is used to correct the angulation of the fracture. The plaster is supported in this position until it is sufficiently hardened. To avoid points of pressure, care is taken to use the flat parts of the hand rather than the fingertips. If there is a Colles fracture, where the distal part of the radius is displaced to the dorsal side, 3-point fixation is placed in an opposite way as is shown in the film Short Forearm Cast. Following the application of the splint, it is important to check if the palmar crease is exposed and the patient is able to flex the metacarpophalangeal joints. Note that the thumb is able to fully abduct. The distance between the plaster and the elbow joint should be at least 2 finger breadths to allow bending when it is placed in a triangular bandage and to ensure that the plaster does not irritate the skin. Finally, the capillary refill is reassessed and compared to the initial findings. Note that the application of the triangular bandage is demonstrated using a clip from a different film, ulnar gutter splint. The application is the same as for the volar forearm splint. The longest side is positioned over the shoulder of the unaffected arm. The other side is positioned over the shoulder of the affected arm. A reef knot is used to fixate the triangular bandage. A safety pin is used to attach the triangular bandage to itself, making sure to support the elbow. This completes the application of the triangular bandage. Note that the hand is positioned higher than the elbow to prevent swelling of the forearm and hand. It is advised not to use a sling, because a sling may cause indentations in the plaster, which may cause pressure complications.